After studying at the Biotechnical University of Ljubljana, he specialized in nutrition and became interested in the cannabinoid mechanisms of action, synergistic interactions with other constituents, and their impact on modulating the endocannabinoid system. So with us and from Slovenia, please welcome Gregor Zorn.
Thank you very much for that presentation, and of course I would like to thank the organizers for inviting me. And today I'll be talking about the therapeutic potential of the so-called minor phytocannabinoids. So phytocannabinoids, what are they and how many do we have? Over 170 have been isolated from this plant that we call Cannabis sativa linnae, and this doesn't mean, of course, that each and every plant has 170 of these compounds in it. Usually there are a few in higher quantities, and most of them are very limited quantities, hence the name minor cannabinoids. Now, other constituents have also been isolated from these plants, such as terpenes and terpenoids, as well as flavonoids. But today we'll focus on these phytocannabinoids, and both the terpenoids as well as the phytocannabinoids are produced in the plant on specialized structures called trichomes, and these are present on the green parts of the plant, specifically at the highest amounts on the female inflorescences, unfertilized inflorescences of the plant. Okay, so we can see here a beautiful electron microscope photograph of these trichomes, and we can see here this is a stalk and this is the gland. This is where they are produced, and this is where they are stored. So these are stalked glandular trichomes, one of the 6 that are present in the cannabis plant, and these produce the higher quantities of these active constituents. And this is a typical diagram of the synthesis, of the production of these phytocannabinoids in the plant. And we can see here that we have GPP, or geranyl pyrophosphate, which is combined with an acid, in this case olivitolic acid, to produce CBGA, cannabigerolic acid. As mentioned before by the speakers, the cannabis plant does not produce the so-called THC and CBD, so the neutral cannabinoids, but it produces cannabinoids or phytocannabinoids in the form of acids. And we term them phytocannabinoids because, to distinguish them, because phyto meaning plant, from the other endogenous cannabinoids or endocannabinoids that are produced in our bodies, as well as the synthetic cannabinoids that are, of course, synthesized. From CBGA, which is the precursor, depending on the enzymes that are present in the plant or expressed in the plant, then CBGA is converted into CBDA or THCA or CBCA. So these enzymes called synthases actually produce these precursors to the well-known neutral cannabinoids. So CBDA is then converted to CBD, THCA to THC, delta-9 THC, and this process is called decarboxylation. It's usually done by heating an extract or vaporizing flower, and this is the general diagram that we have. But if instead of this acid we introduce another acid, let's say divarinic acid, instead of CBGA we get CBGVA. So this is the varinic form, or a cannabigeovarinic acid, and this produces a whole different range of phytocannabinoids. It produces THCVA, THCBDVA, and CBCVA. But the synthases are the same. It's just the product that's different. And of course, when we decarboxylate these acidic precursors, we get other forms of phytocannabinoids. We get THCV, we get CBDV, and CBCV. But there are other types of acids that can go into this equation. So depending on the acid, we get different products. And now we can start to see how we can get so many different types of phytocannabinoids. And already in 2016, they did isolate from high CBG extract cannabinoids that had from C1 to C7. So what are we talking about? We are talking about this tail. This tail is the only difference in these all major families of so-called phytocannabinoids. So we can have from C1 to C even 8 carbon atoms, and this makes different precursors, and then this makes, of course, different neutral cannabinoids. And here are the main structural types that we have in cannabis. And there are 10 major categories, and we have the typical delta-9 THC, delta-8 THC, CBG type, CBC type, and so on. And when we combine all of these 10 different categories with all the different side chain lengths of the carbon atoms, so from 1 to 7, we can get a whole myriad of different natural products. Some of them are actually synthesized by the plant. Some of them spontaneously rearrange in the plant to form other, let's say, categories of phytocannabinoids. The first one that I'll be talking about is CBG, or cannabigerol. Now, cannabigerol is an interesting phytocannabinoid. It was isolated in 1964, the same year as delta-9 THC, 1 year before CBD. It's non-intoxicating, does not provoke the high or the intoxication that THC does. But it does have activity on the CB1 and CB2 receptors. On the CB1, it's a weak partial agonist with very low affinity, and on the CB2 it has a bit higher affinity, but again, it's a weak partial agonist. But what's interesting is the effects that it has via other receptors, such as the PPR gamma nuclear receptor or the serotonin 5-HT1A receptor, as well as the alpha-2 adrenal receptor, and also on ion channels, such as the TRPV1 to TRPV4 ion channels and other ion channels. It also indirectly affects the endocannabinoid system by being an inhibitor of anandamide reuptake into the cell. Now, you might have heard these phrases from mostly people who are selling CBG, that it is the mother of all cannabinoids, or that CBG is a precursor of delta-9 THC and CBD. We can see again here from this diagram that CBG is not a precursor to anybody. CBGA is the precursor to the precursors of delta-9 and CBD, to the acidic forms. And again, it's not a mother of anybody or anyone. CBGA can be a mother of the 5 side chained or the pentyl phytocannabinoids, the typical THC and CBD, but we have many other mothers. What's interesting, of course, are the effects that have been shown in many preclinical trials on CBG, and it has shown analgesic as well as anti-cancer effects. It's also very interesting to be an anxiolytic and antidepressant, similarly to CBD. Its antibacterial effects are extremely interesting, especially against antibiotic-resistant bacteria, and we'll talk about this a little bit later. It also has neuroprotective as well as neuromodulatory effects, and it acts also as an anticahectic, especially in chemotherapy-induced nausea. It's also an appetite stimulant, similar to THC, but working in a different way. And it has potential in quite a different variety of diseases, such as neurological disorders, Huntington's disease, Parkinson's disease, ALS, multiple sclerosis, as well as inflammatory bowel diseases. Now, the problem, of course, with these minor cannabinoids is their obtainative, to obtain them, of course. And usually we had high THC, high CBD plants or balanced plants. The problem was that high CBG plants were unavailable until recently. But the problem is, of course, to not have expressed these synthases that produce the other acidic cannabinoids. So if you get a plant that doesn't express these, genetically express these synthases, the remaining cannabinoid is CBGA. And then, of course, when we decarboxylize, we get high CBG extracts or flowers high in CBGA. Recently, also, seeds of high CBG plants have become available from Dutch Passion, and they have about 10 to 12% rate or percentage of CBGA in these plants, and this again makes it so that people have a source of CBG flowers, and of course they can make extracts. But if we look at the history of hemp, CBG dominant hemp has been already discovered in 1986, where they found this plant that again didn't have expressed these synthases, and it had about 1.15 of CBG, which is not bad. But also other hemp varieties have been available, mostly grown for fiber or for seeds. These French hemp varieties, Santica 27 or Santica 70, which have about from 0.5 to 3-4%, usually 1 to 2% of CBG. And they also have been becoming recently more popular because of their production of CBG and not producing THC. Now, also another interesting thing is this year, a couple of months ago, the first CBG-rich hemp variety was approved on the European list of the available or the hemp seeds that can be grown in the European Union, and this was an Nectarol from Italy, and it produces from, let's say, 4 to 6% of CBG. Again, this gives us more sources of high CBG plants and more sources for extracts. Of course, these products have been available in Europe, as far as I remember, at least since 2017, 2016, mostly CBG oils, pure CBG oils, or mixed in a 1-to-1 ratio thereof with CBD. But the European consumer still doesn't know these products, and we don't have really much data on if they're used or how they're used, because they're still in the CBD phase, still discovering CBD in a way, and not really distinguishing between CBD and CBG. So, but in America, in the United States, there have been products that have been available for our patients for a longer period of time. They have been using them, and we have more interesting data, which led to this study that was published last year, the survey of patients employing CBG-predominant cannabis preparations by Russo and colleagues, where they surveyed 127 participants that use CBG-predominant products. These are products that had over 50% of CBG, and they had to have used them in the last 6 months. And they were from the United States, and they were over 21 years old. And the administration method, interesting, was mainly oral, as we can see here, 76.4%. They also smoked it and vaped it. But the interesting thing for us is why they use it for. And we can see here that they mostly use it for anxiety, for chronic pain, depression, insomnia, and disturbances in sleep, migraine, and headache. But if we look at this, we can see that they use it for a whole wide range of different medical conditions, such as acute pain, which is also interesting, nausea, irritable bowel syndrome, cancer treatment, autoimmune disease, bacterial infection as an antibiotic, high blood pressure, osteoarthritis, menstrual cramps, premenstrual syndrome, Crohn's and ulcerative colitis, and glaucoma and fibromyalgia, and so on and so on. So quite a wide variety of different medical conditions. And also, 34% of them reported using CBG just for general wellness in a similar way like we see in CBD. Now, if we compare CBG predominant cannabis products with conventional medications, and they compare them in their effectiveness, they found that CBG was indicated to have greater effectiveness than the conventional medications, specifically in these medical conditions or symptoms like chronic and acute pain, insomnia and sleep, nausea, irritable bowel syndrome, other types of inflammation, as well as depression and anxiety. Also interesting to note that for around 16.5% of the responders that use CBG for Crohn's and colitis and irritable bowel syndrome endorse CBG as significantly more effective than conventional medications. And we know for these types of medical conditions, the usual conventional medications are really not effective, but CBG was very effective. Now, they also compared the preference, what these patients preferred, and significantly more people preferred CBG predominant cannabis to conventional medications, again, for these indications: chronic pain, acute pain, sleep and insomnia and sleep disturbances, migraine, headache, nausea, irritable bowel syndrome, autoimmune disease, anxiety, and depression. And another interesting data point, for none of these conditions were conventional medications reported to be more effective than CBG, meaning that CBG was more effective than all of these conventional medications, which again tells us that these people were using the right product for the right indication. Of course, we have to talk about the side effects, and 44% of these surveyors didn't report any side effects. And the most prevalent side effects that were reported were dry mouth, sleepiness, increased appetite, and dry eyes. And we can see here that some of these are typical side effects of THC. So we can assume that people who were using these products had higher quantities also of THC. Now, if we look at the anecdotal evidence from forums, we can see that there's a similar picture of why people are using CBG dominant products. And again, mainly using it for pain, different types of pain, chronic pain, mainly neuroinflammatory pain and neuropathic pain, for inflammation, for also muscle relaxation, spasms and muscle tension, as well as anxiety and ADD, autism, which was mentioned also in with the previous speaker, IBS-related stomach pain, appetite stimulation, again similar to delta-9 THC, enhancing productivity, as well as concentration, focus, so general things that they used CBG for. Now, the areas of interest that right now are being investigated scientifically for CBG, I'll mention two. One is cancer. As we can see here, many preclinical studies have shown that CBG was effective in reducing and killing these cancer cells, specifically in breast cancer, prostate cancer. And we know these two types of cancers are predominant, specifically in females and males. And also colon cancer, glioblastoma multiforme, which is a form of brain cancer, as well as melanoma and different types of carcinoma. So this is one area where CBG, but also CBD is being investigated. Another area is the antibacterial activity of CBG. Again, as mentioned before, there is a problem with bacteria developing resistance to antibiotics, and CBG has shown specifically antibacterial activity against gram-positive types of bacteria. There are two families, they're gram-negative, gram-positive, and these also gram-positive bacteria that are resistant to antibiotics such as MRSA and MSSAA. So, and also it was mentioned before, the biofilm. So the biofilm is like a protective layer, it's like a barrier that these bacteria produce, and it can be difficult for antibiotics to get to these bacteria, but that's not a problem because CBG can prevent the formation of these biofilms. And also another important thing is that there was no sign of drug resistance. We usually see with antibiotics that bacteria develop this drug resistance against antibiotics and they're no longer effective. With CBG, there was no drug resistance development, which again is fantastic in a sense. And also it had antiquorum sensing activities, which is just communication between these bacteria. And we can see here again from this diagram, similarly to CBD, also CBG has all of these effects, doing antibacterial activity, also anti-biofilm activities, as well as anti-quorum sensing activities. So great potential, and maybe, hopefully in the future, we'll see a whole line of new products of so-called antibiotics, cannabinoid-based antibiotics. And here are just a few of the studies we can see against different strains of bacteria. And yes, strain is the term used for bacteria and viruses and not for plants or cannabis. And let's go to the next phytocannabinoid, and this is delta-9 tetrahydrocannabinol, or delta-9 THCV. And this is another interesting cannabinoid, as I mentioned before. It is from the varin family, and the only difference between its big brother delta-9 THC and delta-9 THCV is the side chain. So instead of having, this has 3 carbon atoms, 1, 2, 3, and THC has 2 more. And that's the only difference, but that difference is very important because it changes how it acts in our body and its activity. It was isolated in 1970, and it is non-intoxicating, unlike THC. The receptor activity, and this is very interesting, depending on the dose, it can act mainly on the CB1 receptor as an antagonist, but also as an agonist or an inverse agonist. And on the CB2 receptor, it mainly acts as a partial agonist, so activating it, but also so antagonistic activity has been recorded. It also has effects via these ion channels, 3B1, 3B2, and so on. Of course, the interesting part is its potential effects. It has shown analgesic effects, anti-inflammatory effects, also neuroprotection and appetite suppression, unlike the previous cannabinoid, glycemic control, as well as antiepileptic and anticonvulsant effects, antipsychotic effects, and when used topically, also anti-acne effects. it has potential, let's say therapeutic potential, in a wide variety, again, of different diseases such as metabolic syndrome, type 2 diabetes, obesity, Parkinson's, epilepsy, different types of inflammation, nausea, psychosis, and again, when used topically, against acne. Now, 4 clinical trials have actually been done with THCV, and this was mainly from 2015 till the end of 2016, where they investigated THCV for a variety of different things, but mainly for metabolic syndrome, type 2 diabetes, glycemic indexes, and lipid parameters, so these types of things. And it was quite successful, but we haven't seen any drug development, any mention from that time. So this is interesting. Hopefully we'll see in the future more work done with this phytocannabinoid. But again, there is a problem of availability of this phytocannabinoid. It's quite rare. It's present in some chemovars that are from Africa, specifically South Africa, also present in South or East Asian hemp, specifically Chinese hemp, where we have higher quantities in general of the variants compared to European hemp, but we don't have high THCV cultivars. And they did develop recently this THC Victory, which is not a dominant THCV, but a one-to-one, let's say, THC to THCV cultivar. These were the seeds that were developed. But again, we do need plants that are high only in THCV, because THCV, when it's with THC, has a totally different effect. It enhances some of the effects of THC while reducing some other effects. But THCV is what we need, and hopefully in the future we will see THCV predominant plants. And just as a side note, GW already in 2016, they developed THCV predominant plants that had 93.6% of total cannabinoid fraction that was THCV. So these plants can be developed. Of course, GW is keeping this for themselves, but again, hopefully in the future we will see high THCV plants, and patients will have more opportunities to have these kinds of products available to them. The next minor phytocannabinoid is delta-8 tetrahydrocannabinol, or delta-8 THC. And unlike the previous two, this one is not biosynthetically produced by the plant. It's not made by the plant via enzymes, but it is an isomer of delta-9 THC. And it was first derived from the cyclization of CBD, which is now being used quite extensively in the United States, as it is a gray area produced from hemp derived from CBD derived from hemp. And a lot of people in the United States are using delta-8 THC, mostly via vaping or orally. And they found that it was, like THC, intoxicating in humans. It is present in most cannabis plants, as we can see here from the diagram, as an isomer from delta-9 THC at very low quantities, of course. But what's interesting is that it's more stable and resistant to oxidative stress degradation compared to delta-9 THC. So it's more stable, it's more fixed, it's easier to work with. It is similar in its activity on the CB1 and the CB2 receptor, like delta-9 THC. It's a partial agonist, but there isn't really much information on its activity on other types of receptors or ion channels. So a lot of work needs to be done in this sense to know how it works. And if you compare delta-8 to its big brother, delta-9, we can see the pharmacology is very similar. They have similar activities in vitro, in vivo, in humans, but delta-8 THC is weaker than delta-9 THC. And that's one of the positive things about delta-8. Smoked, they did some tests mainly in the 70s, 80s, 90s, and they found that it was twofold less potent than delta-9. It was from 2 to 3.7 times less potent than when used orally, and it had a 6.3-fold less potent binding activity to the CB1 receptor. Hence, in general, it was less potent than delta-9 THC. But if we look at the metabolites, so the first pass metabolism produces these metabolites. These are 11-hydroxy delta-8 or delta-9 THC. This is the first metabolite and the major metabolite, and it's also intoxicating. It produces the high. And these are, for both of these, for delta-8 as well as delta-9, these metabolites are actually more potent than their precursors, or delta 9 or delta 8 THC. And they have, here in this test, they found that it was 2.3 times more potent, had a stronger binding activity than delta 8 THC. And this is also interesting, and it's one of the reasons why when taking cannabinoids orally, we have a different effect and we have a higher chance of having these unwanted highs, so to speak, or intoxication or overdoses, whatever you want to call them, because we get over 90% of course, of the delta 8 or delta 9 gets metabolized into these metabolites. And when looking at the typical tetride acid test, where we see these cannabinomimetic effects, so the typical hypolocomotion, hypothermia, catalepsy, and analgesia, so we can see here, this is the typical test to determine if something is cannabinomimetic, or if it acts like a cannabinoid like THC does. And THC is the standard, this is done on mice, and we can see that these tests show that THC induces hypolocomotion, so decreased spontaneous horizontal activity. It reduces the body temperatures. It impairs catalepsy, mice freeze, and also it decreases pain sensitivity. It has these analgesic effects. And all of these effects, as we can see here, are dose dependent. The higher the dose, the more of this effect is produced. And delta 8 THC produces all of these effects. Now, regarding studies done, there aren't much studies, but this study was on the subjective feeling or the perceived effects that people using delta 8 THC had compared to delta 9 THC or compared to CBD. And as they reported, compared to delta 9 THC, again, these were the phrases that they wrote in the survey, the drug effect, bad effect, sick, anxiety, paranoia, irritability, restlessness, memory problems, and trouble performing routine tasks were lower for delta 9 THC compared to lower for delta 8 THC compared to delta 9 THC. So again, showing that delta 8 is weaker than delta 9. And compared to CBD, which is really not a fair comparison because CBD doesn't produce any intoxication, the effects from delta 8 THC were higher for drug effect, but also for good effect, high, relaxed, sleepy, hunger, having the munchies, memory problems, trouble performing tasks, and paranoia. So again, it was stronger than CBD, of course, because CBD has no intoxication effects. As I mentioned, not many studies, but we do have some information on why and how people are using delta 8 THC products. And again, many of them are using these products recreationally. But of course, there are some people who are trying them for their medicinal problems, medicinal use. And we see, again, similar to THC, to delta 9 THC, but because it is weaker, they don't have some of the unwanted side effects, such as anxiety, such as paranoia, intoxication, so on. So it's used in mainly the same medical conditions, but it's easier for them to use them, specifically for pain, for different types of chronic pain, headaches, as well as sleep problems, and also mental health issues, where THC sometimes can be too much and can provoke some of these unwanted side effects, but people are using delta 8 for OCD, for depression, anxiety, again, panic attacks, post-traumatic stress disorder, but also for ADD, as well as, again, for just better quality of life. And this is a study I have to mention. It was a study done in 1995. Again, very few studies on delta 8 THC. And this was a study done specifically on children from 3 to 13 years old, 8 children that were having anti-cancer treatment. And delta 8 was tested for its antiemetic, so against nausea and vomiting. And this study was meant to be a double-blind, placebo-controlled study. So half of the patients would receive delta 8, half would receive a placebo. But when they started the study, they saw that exactly who was taking the delta 8 and who was not taking the delta 8. Because the children who were not taking were still nauseous and vomiting. The ones that were taking it were actually fine. So they changed it for ethical reasons to an observational study or open label trial, and they found out that, as they noted, delta 8 in an open label evaluation was found to be an excellent pediatric antiemetic with non-significant side effects. And again, the quantities were not low that these children were taking, 18 milligrams, but we know that children are extremely resistant to the side effects or to the intoxication of delta 9 as well as delta 8 THC. Of course, after this study, nothing was done, and we're still here talking about and not knowing the potential of delta-8 THC. But hopefully in the future we'll see more studies and we will have more availability of data. The last one that I'll mention is CBN, or cannabinol. Like the previous phytocannabinoid, this one is actually not synthesized by the plant, as we can see here, synthetically, and it's actually the first one that was isolated from cannabis or hemp in 1896, structure identified in the 40s, and as we can see here, this is a product, it can be a product of oxidation of THCA, so tetrahydrocannabinolic acid, to CBNA, and then via decarboxylation we get CBN, or just from delta-9 THCA we get an oxidation product which is CBN. Is it intoxicating? Mostly not, but it does have activity on the CB1 as well as the CB2 receptor relative to THC. It's about, let's say, a quarter of the potency. It also has effects via all of these ion channels. So again, multiple routes of activity in the body. What's of course interesting is the effects that it has, and it has analgesic, anticonvulsant, as mentioned before, effects, anti-inflammatory, antioxidant activity, antibacterial activity, as well as activity against specific cancer cell lines, and also it has activity in promoting bone formation. It has potential in ALS, Huntington's disease, psoriasis, glaucoma, and as well as an appetite stimulant. And this is what, the 4th appetite stimulant so far. So quite a lot of these cannabinoids have very similar effects. If you look here on this diagram, again, with inflammation, with pain, they all have similar effects. And the magic of cannabis is really when we combine all of these cannabinoids in different preparations. This is the true therapeutic value of this botanical medicine, combining different cannabinoids in different ratios, in different quantities, with different types of administration, with the other constituents found in cannabis, such as terpenes, terpenoids, flavonoids, and so on. And because all of these compounds together, and it has been demonstrated in many studies, can enhance some of the beneficial effects as well as reduce some of the unwanted effects. And just a few examples of this collaboration, let's say, between cannabinoids, in this case in appetite, talking about CBG specifically, they showed that CBG extract had similar potency than purified, similar efficacy than purified CBG, but had a higher potency than only CBG in appetite stimulation. In regards to cancer, we can see that the combination of CBG and CBD each at sub-cytotoxic concentrations results in an additive effect on reduced cell viability and induced apoptosis. So by themselves, the lower quantities did not have effect of CBD and CBG, but when put together, they had an effect on cancer cell lines. Also in pain, the combination this time of CBD and CB1 at a balanced 1-to-1 ratio induced longer lasting reduction of mechanical sensitization than other compounds alone. Again, showing this synergy or enhancement of effects or modulation of effects. And this is actually what patients are already doing, where the availability of these phytocannabinoids is present, like in the United States. They're already mixing and matching and trying CBG with delta-8, with CBN and so on, and trying for their specific medical conditions for treatment of their specific symptoms. And this is what cannabis is and should be. It's personalized medicine. And hopefully in the future, for everyone, there will be a personalized variant of all of these products, so it will be specific for that patient, for that indication, for the treatment of whatever needs to be treated. Thank you very much for your attention. Do we have time for questions? Yeah? I was fast, right? I was fast.
Quite on time. Quite? Maybe battery? I will get one. Meanwhile, if I can make a request, a dark brown wallet with documents in the name of Jose Cabrera was lost. If someone finds it, please give it to the reception so that the person can get the wallet back. And now I have microphone back. So please, Gregor. And if anyone has questions, would you please raise your hand? And it will be a pleasure to give you the microphone. If we can have some light in the audience so that
It's a shy audience.
It's a shy audience.
Yeah.
No, maybe it was lunch.
Maybe they understood everything or they didn't understand anything.
It was
That's
so
it is-
amazing, so amazing that there are no questions for you. I guess there are.
No questions.
Oh yes, there we have. You see?
Is it on? Here we go. Thank you, Gregor, for that. Out of all the minor cannabinoids that you discussed today, is there one that you are more excited to learn more about and see more research about in the near future?
Yes, absolutely. Delta 8 THC, because there's no research, regarding it, and it has such great potential. Having the qualities of Delta 9 THC, it has all the qualities without the potency. Without the I have to go to the center. Without the potential side effects that are usually present with Delta 9 THC. So it has great potential. Plus, it's very stable. It's cheap to make. It's much cheaper to make than Delta 9. Plus, but it has to be made. So that is one issue. It's not plant derived. But as I mentioned in my last slide, the potential when combining Delta 8, let's say, also with other phytocannabinoids, such as CBD. At what ratio does CBD have this effect that it has with Delta 9 THC in reducing completed intoxication of Delta 9 THC with Delta 8 THC? We don't know. And combinations with other cannabinoids, such as CBN, are also interesting. Also, with the other phytocannabinoid that they're very interested is THCV. Again, great potential, specifically for metabolic syndrome, for all types of diseases regarding the cardiovascular system, because it's a CB2 agonist, so it activates the CB2 receptor, blocks the CB1, which is very interesting and again non-intoxicating, specifically for types of metabolic problems, cardiovascular problems, diabetes, and so on. Plus, it may reduce hunger, so it could be also used in that sense. It's one of the only ones. All the other ones just enhance appetite, right? So again, combinations are interesting. And then when you combine the terpenes, how does myrcene react with Delta 8 THC? Does it have this sedative effect like it has with Delta 9 THC? Or the other, let's say limonene or alpha-pinene, which are very enhancing or alerting, do they have the same effects with Delta 8 THC? Again, a lot of questions, huge amount of work to be done, and a lot of potential, I think, for companies to really discover these minor, so-called, but minor only in the quantity, not in the effects or their potential phytocannabinoids. I hope I answered your question, yeah? There you go.
Thank you. We have another question.
I have another question.
Okay.
Thank you, Gregor, for your presentation.
You're welcome.
My question is, you just said we don't have enough research around Delta 8 THC.
Yeah.
But we have a huge market right now.
Yeah.
So I want to know your thoughts around
It's a gray market. So again, this is specifically for the United States, where they have this law that anything that is produced from hemp and CBDs produced from hemp is legal in a sense, and it's again state by state they're fighting this, but a lot of these products, specifically vapes, Delta 8 vapes, are found even online, and people are acquiring them and they're using them mainly for, let's say, recreational use, because it's kind of legal, so a lot of people are using it. But also we're seeing people again discovering Delta 8 because of the fantastic effects it has, beneficial effects, without all the unwanted effects that some people are so sensitive to. We know that with Delta 9 THC, there is a sensitivity, let's say with women, they're usually 2 times more sensitive, on average, of course, to Delta 9, and specifically in cases like we saw, we were talking about the biphasic effect, where lower quantities had one effect, higher quantities have the opposite effect, and even there's a triphasic effect. Even higher quantities have, again, the opposite effect. So maybe with Delta 8, they don't see this effect, but they see all the benefits. And it's cheap in a sense, it's available for now, but in Europe, again, it's a whole different game, because it's part of the THC bunch. So it has this name that, again, even THCV can be problematic, because it's the brother of THC, but it is not intoxicating. The studies done at GW, they use 10 milligrams of THC in males and orally, and it didn't produce any effect. So again, but it has the name. So CBG sounds a little bit more like CBD. So it's more, let's say, acceptable. THCV sounds a little bit too much like Delta 9 THC, right? So It is in the same basket as THC, but it's not. It's totally different because again, that side chain totally changes how it reacts with the CB1 receptor, but it has incredible, again, therapeutic effects. Did I answer your question about Delta 8? Good.
Thank you so much. We have another question right over there. Yes?
Hi, Gregor.
Hello.
Thank you for the presentation. Just adding to the point that you just made regarding Delta 8 and Delta 9, the reason in the US why everybody goes, it's got Delta 8 is because at federal level, they reference Delta 9 specifically as an error by the Senate, or deliberately. You correctly point out, though, that at European level, and even in the UK, we list out all the THCs, rightly or wrongly, and everybody's just clubbed together. My question to you on a scientific level is that we're still discovering all the cannabinoids, and do you believe that there could be other, if I can use the phrase, THC type cannabinoids still yet to be uncovered, and where do you see that going?
Well, they could be, but the majority of them were already discovered. So we know that the THC family, we can have, again, the side chain from 1 to 8 or to 7. So the 7 one has been discovered 2 years ago, officially discovered. It was actually isolated in 2016 and even before. And this has shown greater potency than Delta 9 THC, actually 30 times greater potency on the CB1 receptor. But again, we don't. It's in so small quantities. It was isolated from the FM2 Italian variety of medical cannabis produced by the military, but the quantities are very, very low. So they had to synthesize to test it and to see the effects. Again, having plants that produce only this type of phytocannabinoid, they're non-existent for now. They might be, but the other issue is, do they have any therapeutic value? Can we use them so strong? We don't know that because they haven't been tested. They could have potential, but I don't think that we'll find any more THC-like, so intoxicating phytocannabinoids in cannabis plant. We might, but the vast majority, 99% of them are non-intoxicating. And those are the ones that are more interesting because, of course, intoxication, apart from the recreational side, is something that most patients do not want. They just want to have a normal life, right? Take their kids to school, go to work, and so on. So intoxication is a big problem in every single study. It's always mentioned about THC. The bad side is intoxication, is all of these side effects. And if it doesn't have, a phytocannabinoid doesn't have these side effects, it's much more open to studies and to the application, even for medical use with professionals, because again, having something that doesn't have all of these side effects is more appropriate in a sense for treating people. Did I answer your question? Yeah.
Thank you. We have a last question right over there on this row.
Thank you so much for your presentation. It's really interesting.
Where are you? I can see you.
Question. Sorry?
Where are you?
Right. Can you raise your hand?
Thank you.
With the camouflage.
Yeah.
So I'm a grower, right? So I look at it from the cultivation point of view.
Okay.
From your experience, is there any difference between hemp derived CBD or cannabis based cannabis? Cannabis based CBD?
For CBD specifically?
CBD and other, obviously, THCs don't exist in hemp, but yeah.
Okay, thank you for the question. Well, let's say chemically, it's the same molecule. It's the same. Of course, the cannabis plant produces only one type. If we talk about THC, we're talking about isomers. So different. When we're seeing, let's say, a structure of THC, it's 2D, but the structure is 3D actually. It's a 3D space. So we have 4 different isomers of THC. We have the trans, the cis, and we have the plus and the minus cis and trans, so 4 different types. The plant produces only one type. It's a minus trans delta 9 tetrahydrocannabinol, so only one type. So the problem is, of course, in the synthesis, and I will mention that for delta 8 THC, the problem with the synthesis or from CBD to delta 8 THC, that you get a lot of side products, a lot of stuff that shouldn't be there, a lot of impurities, even then delta 9 THC, and a lot of other stuff, even some terpenoids. Regarding the plant, the CBD is the same, but what it comes with is different. And here we usually see, and we have seen this, that extracts made from hemp for medicinal use compared to extracts that are made from high CBD plants, the high CBD plants extract are usually work better. Despite the fact that they might be the same compound, the same, let's say, percentages and ratios of these compounds, of CBD and THC, but the other compounds, these are the important ones. As I said, this plant is, again, it has a magical thing to it. We still don't understand why some of the compounds have this effect, this synergism, this enhancement, this modulation, and which compounds are actually making these, let's say, differences. So there is a difference. I believe there is a difference, and there is a higher quality of medicinal types of extracts made from specific cannabis. The higher the quantity you have of phytocannabinoids in the plant, the more it produces other compounds. The lower the quantity, if you try to restrain, like with hemp, with 0.2, 0.3 THC, you restrain all the other compounds of the plant. It doesn't produce the other compounds at the same quality, at the same levels. So the overall efficacy goes down. And that is the main, I see, difference between hemp and high CBD plant extracts.
Thank you so much. Again, one applause for Gregor Zorn. Thank you so much.